I'm very pleased to announce our speaker for today. We have with us Kowuthamie Tharma, and she is a genetic counselor at the Juravinski Cancer Centre and is certified by both the Canadian Association of Genetic Counsellors and the American Board of Genetic Counselling. She graduated from the University of Toronto with a Master's of Science in Genetic Counselling and has more than 7 years of genetic counseling experience. She is also currently a member of the CIBC Breast Assessment Center Research Committee and has a special interest in personalized medicine, patient advocacy, research, and increasing access to genetic counseling services in the community. So I'm very pleased to pass the presentation over to you, Kowuthamie, so we can get started.
Perfect. Good afternoon, everyone. Thank you for joining the webinar series. I'd like to thank Wellspring for the opportunity to engage in these webinar series and to present to you today. My goal is to provide an overview of hereditary cancer genetics and if genetic counseling services are appropriate for you and your family members. So on the agenda today, we're going to be taking a look at who are genetic counselors and what does a genetics assessment look like. What is hereditary cancer? We'll go over some case examples of hereditary cancer, discuss genetic testing and possible implications, the role of genetic counseling in preventive medicine, and we'll also discuss how to access genetic counseling services in your community. So starting off with, who are genetic counselors? So genetic counselors are healthcare professionals with specialized training and experience in the areas of medical genetics and counseling. So genetic counselors help identify individuals and families who may have or be at risk for a genetic condition. So they typically provide individuals and families with information on the nature and the inheritance of genetic disorders. We also review available options with the individual and or family, including screening or management recommendations, and discuss genetic testing options in a manner that promotes informed choice. Genetic counselors also provide supportive counseling to individuals and families with sensitivity to ethnic and cultural diversity. So we also consider potential ethical issues that could also arise for an individual and or their family. Genetic counselors can work in a number of different roles and specialties. So we can work in hospitals, public health, education, and the private sector. We also work in a number of different specialties, including prenatal, pediatric, genetics, neurology, metabolic genetics, cardiovascular genetics, and cancer genetics. So this is our team at the Juravinski Cancer Centre. So we have 4 genetic counselors. We also work with a genetics assistant, a data analyst, our manager, and we also work with 2 medical oncologists with a special interest in cancer genetics, and they follow all of our higher risk patients. So when we think about cancer, a majority, so about 65% of cancers are sporadic. So sporadic cancers are cancers that occur by chance and may be the results of exposures that increase their risk. So for example, smoking. Sporadic cancers are often cancers that are later onset, meaning they're diagnosed at a later age, and often occur as a single occurrence in a family. These individuals typically do not have a striking family history. So for example, an individual who's diagnosed with breast cancer at the age of 70 with no other family history of cancer is considered to be a likely sporadic cancer. Now, about 15 to 25% of cancers are considered to be familial. So familial cancers are cancers that occur due to a combination of familial and environmental factors. So family members may share common genetic factors and environmental exposures or lifestyle factors that may put them at a higher risk for cancer. So for example, an individual with breast cancer at 60 and a maternal aunt with breast cancer at 65 with no other family history. And lastly, the piece that we're most interested in, the hereditary cancer piece. So that's about 5 to 10% of all cancers, meaning that there is an underlying genetic change or a mutation in the family, or there is a striking family history that's suggestive of a hereditary cancer syndrome. In these families, we often see young ages at cancer diagnosis, individuals with multiple primary cancers, and multiple individuals in the family diagnosed with cancer that follows a hereditary pattern. So we will talk a little bit more about this in the next few slides. So when thinking about cancer genetics and a cancer genetic counseling session, what can you expect in an appointment? So one of the first steps is to obtain your medical and family history information. So what we will do is draw a pedigree, which is a drawing of your family history. So we're seeing that on the right side here. So where squares are for males and circles are for females, and individuals who are colored in are those who are affected by cancer. So we will also ask about primary sites of cancer, the ages at diagnosis, and any other associated abnormalities with specific questions. This provides us with information and clues to determine if your family history is suspicious of a hereditary cancer condition. So the second part of the assessment is the risk assessment, meaning we will look at the information that you have provided to determine if your personal medical and or family history is suspicious of a hereditary cancer condition. So we may tell you the likelihood that you or your family member carries a harmful genetic change or a mutation. We may also provide you with information on your risk of developing cancer based on the family history, either using data or various risk assessment models. We can also provide screening recommendations based on the family history of cancer. So for example, we might provide suggestions on breast cancer screening, colon cancer screening, and what your level of risk may be, whether that's low, moderate, or high risk. So here are two pedigrees. So on the left-hand side, we have a family history that's suspicious of a hereditary cancer syndrome. And on the right-hand side, we have a family history that looks more sporadic. So when we collect this information during a session, what we are doing is we are typically looking for different clues. So one of the clues that we look at is ages at diagnosis. So usually, hereditary cancers are often young onset. So for example, 30s, 40s, a little bit more suspicious to us than cancers that occur later in life. The second clue that we look at is how many individuals in the family have been diagnosed. So are we seeing multiple individuals in more than one generation affected by cancer? Another clue that we might look at is what types of cancers are we seeing in the family? So there are certain types of cancers that often go together in a hereditary pattern. So for example, we might see breast cancer go alongside ovarian cancer, prostate cancer, pancreatic cancer. So we're essentially looking for patterns. We might also look to see, are there any cancers in the family that are less likely to occur in the population? So one example is male breast cancer. So male breast cancer in the population is quite rare. We might see it in about 0.1%. And so if we're seeing male breast cancer history in a family, that might be a red flag for us. Another cancer may be ovarian cancer. So ovarian cancer in the general population is also not as common. We might see it in about 1 to 2% of individuals. And so when we see, again, ovarian cancer in a family history, that's another red flag for us. So looking at this family history here, what we're seeing is an individual with a young onset breast cancer at 35. So she's colored in pink. Then we're seeing that her sister was diagnosed with ovarian cancer at 50. So she is that circle with another circle colored in purple. Then their mother had both breast and ovarian cancer. So she's had multiple primaries. So breast cancer at 47 and ovarian cancer at 58. And then their maternal grandmother, now deceased, had breast cancer at 42. So what we're noticing in this family is multiple cancers in more than one generation. There's young onset breast cancer, so breast cancer at 35, breast cancer at 42. We're noticing an individual with multiple primaries, both breast and ovarian, and we're also noticing that ovarian cancer history in the family. And so this may be a family that's suspicious of having a hereditary cancer syndrome or an underlying genetic cause for the family history of cancer. Now, if we're looking at the diagram on the right-hand side, or sporadic cancer, what we're noticing is there's an individual with breast cancer diagnosed at the age of 72. So that might be considered to be a later onset cancer. That might be the result of natural factors like aging. Additionally, there are no other cancers in that family, and so it makes it less likely that there's an underlying genetic cause for this. So when we're assessing a family history, essentially that's what we're looking for, essentially looking at patterns to see if it fits a hereditary cancer syndrome. So when we are thinking about our genetics and genes, we're essentially looking at our DNA. So to take a step back, genes are like instructions for the body. So we have genes for hair color, eye color, and we have genes that are supposed to protect us from developing cancer. And we have more than 20,000 genes, and each of our genes come in pairs. So we get a copy of a gene from our mother, and we get a copy of our gene from our father. So our genes are made up of DNA, and this DNA makes proteins, and proteins are like the instructions for the body. So we have genes that make proteins whose job is to prevent our body from developing cancer. So an example of such genes is BRCA1 and BRCA2, which are tumor suppressor genes, which many individuals may be more familiar with. These genes, so BRCA1 and BRCA2, they work by providing instructions in the form of proteins that keep our cells healthy and from dividing too fast, because we know that rapid or fast cell growth is cancer. So here we have a diagram of a healthy gene and a gene that contains a mutation. So a healthy gene, or a normal gene, is a gene that provides healthy instructions in the form of a healthy protein. That protein is then able to work to keep our cells or our body healthy. Now, a gene that contains a mutation is a gene that carries a mistake in the DNA or in the code. And thus, the DNA is not able to produce a healthy protein, and thus that protein is not able to provide instructions to our body. So it's not able to do its job, for example, to keep a cell healthy and prevent it from dividing properly. So earlier, I mentioned that we have 2 copies of all of our genes. So we always get a copy from our mom, and we always get a copy from our dad. So that's what's sort of illustrated in this diagram here. So you have mom on the left side. She has 2 copies of a gene, and again, we have more than 20,000 genes, but this is just simplified to show you a gene. So mom is coded in pink, and then dad also has 2 copies of all of his genes, and so he's coded in blue. So each time they have children, they only pass on 1 of 2 copies of all of their genes. So mom passes on, we see a pink copy, and then dad passes on a blue copy of that gene. So let's compare how cancer can develop in someone where it's likely to be a sporadic cancer, and how cancer can develop in someone where this may be hereditary. So what we're seeing in the top diagram here is someone with sporadic cancer development. So in this scenario, what we're seeing is this individual starts off with 2 healthy copies of a gene. So it's coded in blue. And those 2 healthy copies are supposed to protect them from developing cancer. A cell in their body may acquire a mutation or a harmful genetic change in 1 of 2 copies. So what we're seeing now is 1 healthy copy and 1 copy that carries a mutation that's drawn in red. The body is still able to provide instructions. The genes are still able to provide instructions to the body because there is still 1 healthy copy and 1 copy that's not working properly, which is okay. Now, if the second copy also acquires a mutation, and that can happen by chance, now there are no working copies, therefore there are no instructions going to the body. And if that gene's particular job was to help that cell divide properly at a controlled pace, Now that there are no instructions going to that cell, it won't know what to do, and what essentially happens is that cell starts to divide uncontrollably or too fast, and that's where we see cancer development. So that's how sporadic cancer may develop. Now, if we turn our attention to the bottom diagram shows us how someone who is born with a mutation may develop cancer. So in that first circle there, that cell, we're seeing that individual with one healthy copy of a gene and one gene copy that is not working properly because it contains a mutation. This is something that they were born with, and they were okay because they still carry that one copy that's working properly, still able to provide instructions to the body. Now, if they lose that second copy in that cell via a mutation, now there are no working copies going to that gene, and the body, again, or that cell, won't know what to do because there are no instructions. So what happens is that that cell starts to divide uncontrollably, and it leads to cancer development. So if we are comparing the top diagram to the bottom diagram, so sporadic cancer to what might occur in an individual who has a hereditary predisposition, we're seeing that there is one less step in an individual who carries a mutation before they develop a cancer. And that's why in hereditary families, what we often notice is that the cancers are younger onset, and we are seeing more of a striking family history. I do want to emphasize, though, that just because someone has a mutation or a harmful genetic change that they may be born with, this does not mean that they will definitely develop cancer. They just may be at higher risk over their lifetime. So we are looking at our genes by genetic testing. So if your family history is suspicious of a hereditary cancer syndrome, you or someone else who is better testable in the family may be offered genetic testing. So a genetic test is essentially a blood test, and what we are doing is reading through the genes that are supposed to protect you from cancer. We're looking to see if you have any harmful genetic changes or mutations that have caused your history and or family history of cancer. And the goal of genetic testing is to identify individuals and families at risk of hereditary cancer. This will provide us with the opportunity to provide screening and or management recommendations to reduce or monitor a cancer risk. And we know that early screening and prevention can help us either prevent a cancer altogether or catch it early so that it is better treatable. So when we are offering genetic testing, we look at both the benefits and limitations of genetic testing and allow that patient and or family to decide whether it's the right choice for them. So in terms of the benefits of genetic counseling or testing, for some individuals, they may be addressing the why. So for some patients who have a personal history of cancer, their question might be, why did this happen to me? And for some, genetic testing might provide them with an answer. It may not provide them with an answer, but it may also provide a sense of relief from some level of uncertainty. The second, it may provide individuals with an in-depth knowledge of their cancer risk. For example, an individual who undergoes genetic testing for a history of breast cancer may learn that they may be at risk of other cancers as well. Knowing what potential cancer risks that they may be faced with, we may be able to provide specific screening and or risk reduction options to manage their cancer risk. So individuals would therefore have information to make an informed choice about their medical care. Genetic testing may also help guide clinicians or physicians in choosing the most suitable therapy for a patient who is affected with cancer. So for example, a patient with a newly diagnosed breast cancer may use the results to make decisions about their treatments, such as surgery. So they may choose, for example, to have a bilateral mastectomy instead of a lumpectomy, which may then impact their subsequent treatment decisions. Another example is a patient with a platinum-sensitive recurrent ovarian cancer with either a BRCA1 or BRCA2 mutation may be a candidate for targeted therapies called PARP inhibitors. So physicians who are involved in your treatment planning may also utilize your genetic test results to help build that treatment plan with you. And the other benefit is to family members. So results can also be helpful for family members because if there is a harmful genetic change or mutation that's found in the family, then they may also be eligible for genetic testing. And if those results are negative or normal, those patients are also counseled based on the family history. Typically, we're able to provide them with screening recommendations. So let's look at the limitations or important considerations when it comes to genetic counseling or testing. So testing may cause some level of emotional distress. So for example, for some individuals, knowing that they're at risk for cancers may increase their stress. They may not be ready to receive this type of information, especially information, that may tell them that they are at risk of other cancers. A lot of patients sometimes describe it as opening Pandora's box. And so they may not be ready to receive that type of information. Some individuals may experience guilt in potentially finding out that they carry a harmful genetic change, and this is something that they may then pass on to their children. There may also be stress associated with having to make decisions regarding screening or management in the context of their results. And for a lot of patients that have recently undergone a cancer diagnosis and just completed treatment, and having to have made a lot of decisions in that period of time might just need a break from that, which is quite understandable. The second, testing may cause family issues. So perhaps there are family members who don't want to have this information, and perhaps holding on to this information may cause distress in a relationship. Testing sometimes can yield uncertain results or results that are unclear, and sometimes that can be difficult to also address or deal with. And the fourth, if testing identifies a mutation, often screening and or management recommendations are made, and thus there may be some risks associated with some of these interventions. So if we are offering genetic testing, there are three possible results that someone might expect. So a positive or an abnormal result means that a harmful genetic change or mutation has been found, and that individual is at increased risk of various types of cancers. So it provides clarification as to what risk this individual might be at, and we would then be able to discuss possible screening and or management options with them. If there is a positive or abnormal result found in a family, then family members would also be eligible for genetic testing. So this is an example of a family who is eligible for testing and where a mutation was found. So the arrow is pointing to our patient, so a 59-year-old who was diagnosed with ovarian cancer at the age of 40. Her brother, a 65-year-old, had prostate cancer diagnosed at the age of 49. And their mother, deceased at age 67, had bilateral breast cancer diagnosed at 50. So this would be a family that's suspicious for an underlying genetic condition, and it would be a family that's eligible for genetic testing, given that we're seeing bilateral breast cancer at 50, we're seeing ovarian cancer, and then we're also seeing a young onset prostate cancer. So this family would have been offered genetic testing in the form of a panel, meaning we're looking at multiple genes that are supposed to protect us from developing cancer. So this particular family was found to carry, for example, a BRCA1 mutation. So in this slide, I'm going to discuss risks that are relevant to both BRCA1 and BRCA2 because they are quite similar. BRCA1 and BRCA2 were actually two of the most common causes of hereditary breast and ovarian cancer in a family. And this was, I think, brought to a little more light with Angelina Jolie. So Angelina Jolie is known to have a BRCA1 mutation, and she spoke openly about her journey and experience as a BRCA1 mutation carrier. She herself underwent a bilateral mastectomy and discussed her experience with this surgery. We know that the general population risk of breast cancer is about 11 to 12%, or 1 in 8 women will develop breast cancer over their lifetime. An individual with a BRCA1 or BRCA2 mutation, their lifetime risk of developing breast cancer can range between 40 to up to 80%. Now, individuals with individuals may also be at risk of ovarian cancer. So general population risk of ovarian cancer is about 1 to 2%, and the lifetime risk when you have a BRCA1 or BRCA2 mutation, that risk is about 25 to 50% over your lifetime. Now, men with BRCA1 or BRCA2 mutations are also at an increased risk of cancer as well. So male breast cancer risk in the general population is quite uncommon, about 0.1%. And we know if you have a BRCA1 or BRCA2 mutation, that risk can increase to about 7% over that individual's lifetime. There's also an increased risk of prostate cancer. So prostate cancer in the general population, we might see in about 1 in 9 men. And when you carry a BRCA1 or BRCA2 mutation, that risk can increase up to 30% over your lifetime. We also know that both men and women who carry a mutation in these genes may have an increased risk of pancreatic cancer. So this is the type of information that we would go over with an individual who either carries the BRCA1 or BRCA2 mutation. And then what we would look at essentially is how to mitigate or how to address this risk. So often the management is tailored to that individual's unique circumstances and their preferences. And the cancer risk management generally includes intensified screening, or a prophylactic or preventative surgery. So, for example, for someone who has a BRCA1 or BRCA2 mutation, in the province of Ontario specifically, they may be eligible for the high-risk breast screening program. This is where you would have access to a mammogram and a breast MRI every year till you turn 69. The other option, and it's not an option for all women, is to consider having a risk-reducing bilateral mastectomy or removal of both breasts, which can significantly reduce risk. The risk level is not 0%, however, because of the fact that we also have breast tissue against our chest wall that cannot be removed. With respect to ovarian cancer, there's currently no effective screening protocols for ovarian cancer detection. And so the current guidelines suggest a risk-reducing bilateral salpingo-oophorectomy, so the removal of both the ovaries and the fallopian tubes. And the fallopian tubes, because a lot of the time ovarian cancer does develop in the fallopian tubes. And so for BRCA1 carriers, it's typically recommended between the ages of 35 and 40 or upon completion of childbearing. And a BRCA2 mutation carriers between the ages of 40 to 45 or after childbearing is complete. With respect to men and the elevated risk of prostate cancer, we suggest starting prostate cancer screening earlier than the general population. So prostate cancer screening, for example, might begin at the age of 45 with a prostate-specific antigen test and a digital rectal exam through the family doctor's office. Given the elevated risk of male breast cancer, we also suggest clinical breast or chest wall examination. And again, that can be completed through the family doctor's office. Similar to ovarian cancer, there is currently no effective screening for pancreatic cancer. And so with pancreatic cancer, we often discuss signs or symptoms, or if there is a family history of pancreatic cancer, for example, in a first-degree relative like your mother, father, a sibling, or a child even, then sometimes what we do is we try to find out if there is a research study-based pancreatic screening protocol. And so we might help that patient enroll in that study if it's appropriate. There has been some data to suggest that there may be an increased risk of melanoma, especially as it pertains to BRCA2 mutations. And so what we might discuss is increased skin checks or skin awareness. So these are examples of sort of management or screening recommendations that we might go through with the patient who has a BRCA1 or BRCA2 mutation. And like I said, it's always the patient's choice as to how much or how little they'd like to do, and go from there. And at our center specifically as well, we do refer our patients on to our medical oncologists that we work with that specialize or have a special interest in genetics, who have sort of a longer-term follow-up with our patients. So that was our positive result or abnormal results. We can also get a negative or normal result, even if the family history looks quite suspicious of a hereditary cancer condition. So a negative result means that no mutations were identified in the genetic testing that was completed. This does not mean that the cancer is not hereditary. And I say that because we've only looked at a subset of genes that are supposed to protect us from developing cancer. Now, like I said earlier, we have more than 20,000 genes. So there could be a gene out there that we haven't yet discovered that's causing that family history. So oftentimes we tell our patients to come back every 1 to 2 years to see if there are any updates to genetic testing. So if we have discovered any new genes, then the patient would be eligible for updated testing. And so if you have had genetic counseling in the past or testing a number of years ago, what I would suggest is contacting your genetics clinic to see if there are any updates to testing today. So I know in the past, for example, we were only doing BRCA1 and BRCA2, but now we are doing more than that. So we're doing a panel of genes. So there are other genes that have been discovered that can cause cancer history. If there is a negative or normal result in the family, we usually do not test family members because we simply have not found anything. And in terms of family members, they may still be referred for genetic counseling to discuss their cancer risk in the context of the family history, and we may then review screening recommendations with them. We can also get a third type of result, and this has become more common as we test more genes. And this third type of result is called a variant of uncertain significance, or it can be thought of as a gray area result. So this is a genetic change that has been found, but we do not know if it is a harmful change or if it's a benign change that's unique to you and your family. We are all very different, and so we do carry unique genetic changes. So this might be just a unique genetic change that does not do any harm, but the lab may not have enough data at that time to make a conclusion about what this genetic change means. So when we do have a variant of uncertain significance, we do not use this result to change your cancer screening, treatment, or risk reduction plan simply because we don't know what this result means. And so if we are discussing your cancer risk or recommendations for the family, it will be based on your personal risk factors and family history of cancer. And typically, we do not offer genetic testing of variants of uncertain significance or these gray areas to family members because we simply, again, do not know what they mean. So these are sort of the three types of results that one might expect when they are undergoing genetic testing. So in addition to going through a lot of this information with patients and possible management strategies, genetic counselors also provide psychological support to patients as well. So they can help a patient and or their family adjust to new information by helping them draw on coping strategies, helping individuals make decisions about their surveillance or management that they are most comfortable with, helping individuals address family issues such as how can I disclose this to my family members, or exploring the impact of these results on the concept of self. For some patients, there may be concerns regarding their future, such as family planning, and so we might explore this concern and different options that may be available to them. Genetic counselors can also help an individual and or their family find resources for support that fit their needs including support groups. So we often get asked about general sort of recommendations. And so we often, especially around lifestyle, so what we tell our patients really, and which is what probably most healthcare providers would tell you, is to have a well-balanced diet, maintain a healthy body weight, moderate exercise, no smoking, and moderate alcohol intake. So I've been talking a lot about hereditary breast cancer and examples of genes around that. In a genetics clinic, we also see patients for a variety of different cancers outside of breast and ovarian. So this is an example of a patient who presented to us with a family history of colon and uterine cancer. So our patient here, female, is indicated with an arrow, and she came to us because there is a striking family history on her father's side of the family. So what we're seeing here is that her paternal uncle was found to have colon cancer at the age of 40. His daughter had colon cancer at the age of 52. Her other uncle had colon cancer at the age of 56. We're seeing that her aunt had uterine cancer at 50 and kidney cancer at the age of 55, so she's had two primaries. And then her daughter, so our patient's cousin, had colon cancer at a young age, so we're seeing age 32. And then our patient's mother also had some type of cancer. She wasn't quite sure what it was, but had some cancer history, but otherwise her maternal family history is unremarkable. So when we're looking at the paternal family history, the patterns that we're noticing, we're seeing young onset colon cancer, we're seeing endometrial cancer and kidney cancer. And so what comes to mind is a condition called Lynch syndrome. So Lynch syndrome is a genetic condition where we can see an increased risk of colon cancer and uterine or endometrial cancer, amongst other cancers like kidney cancer. And so what we told our patient was that typically we like to offer genetic testing to someone who's had the cancer history themselves because we are more likely to find a genetic change. So in this situation, we discussed inviting or discussing genetic counseling for other family members. And these family members who are affected with cancer may be referred to their nearest genetic center for an assessment. And if genetic testing is organized by that center and a harmful genetic change is found in that relative, then we always encourage our patients to recontact us with those results so that we're able to provide the appropriate counseling and offer testing. So for this patient, although they did not have access to genetic testing in this appointment, we did provide them with prevention or screening strategies around colonoscopy based on that paternal family history of cancer. And so this is an example of a family presenting with a strong history of colon, endometrial, and kidney cancer that's suggestive of a different type of hereditary cancer syndrome. So in Ontario specifically, there is the high-risk screening assessment. So we might see patients specifically for this program enrollment. So in this program, patients with a family history of breast and or ovarian cancer may be eligible for additional screening beyond mammograms. So if their lifetime risk of developing breast cancer, and we usually calculate that to age 80, is about 25% or greater, they would have access to a mammogram and a breast MRI yearly. So that's from the age of 30 to age 69. And how we calculate this risk is using various different models that incorporate personal risk factors and the family history of cancer. In these individuals, we may also counsel them on the family history or identify individuals who may be eligible for genetic testing. So we often also get asked a lot about genetic discrimination. So especially if we have a young patient who might be considering genetic testing and is worried about access or eligibility for insurance, especially if they have a positive or an abnormal result. And so what we often discuss is the Genetic Non-Discrimination Act. So on May 4th of 2017, the Genetic Non-Discrimination Act, which was previously known as Bill S-201, was passed in Canada. And so the Genetic Non-Discrimination Act protects individuals from the use of genetic test results in areas outside of medical care and medical research, such as insurance and employment. So under the Genetic Non-Discrimination Act, providers of goods and services, including insurance providers, cannot request or require that a person undergo a genetic test or require the disclosure of previous or future genetic test results. Under this act, federally regulated employers cannot use a person's genetic test results in decisions about hiring, firing, job assignments, or promotions, or request or require genetic test results of an employee. And under this act, the Canadian Human Rights Act bans discrimination based on genetic characteristics. So we do often go through this act with our patients and leave it up to them in terms of how this might impact their decision to undergo genetic testing. A lot of our patients may still set up insurance prior to undergoing genetic testing, just for peace of mind. So again, we leave it up to the choice of that patient and their family. So how can you access genetic counseling services in your community? So if you have a personal and or family history of cancer and you are wondering if you are eligible for a genetics assessment, you can review this information with your healthcare provider. So whether that be a family care provider or a medical oncologist. That individual may then send a referral to your nearest genetic center. And often what these centers will do is they'll receive your referral. They might ask you to fill out some additional information before determining if you're eligible for an appointment. So they might, for example, send you a family history questionnaire that you can then fill out and send back for an assessment. You can also access a list of genetics clinics in Canada on the Canadian Association of Genetic Counsellors website. So I've just listed it down below. So it's www.cagc-accg.ca. So this brings me to the end of my presentation. So again, I'd like to thank you for joining me in this webinar series today, and hopefully I've given you some insight and some helpful information on genetic counseling and genetic counseling services and how and whether that might be appropriate for you and your family members. So thank you again.
Thank you so much for that. That was such an informative talk, and I just wanted to thank you so much for going through that in such detail. And giving a very comprehensive overview of everything genetic counseling related.